Well, I went into nursing initially because I love science and with people. And I didn't think I was smart enough to be a doctor. So I didn't also have the patience to be a doctor. So I thought I was going to be a surgical nurse, actually. I wanted to see like surgery. I wanted to see the blood, the gore, all that type of stuff. And then I went to one surgery in nursing school, one C-section, and I just thought, I'm like, this is freezing. This is boring. I don't want to stand this long. Like those surgical suits are really cool. So immediately I'm not doing that. And then I did my rotation in psych. And I had sworn off psych at this point, mind you, because I had been hospitalized right before I went to college. And I said, hell no, I don't want to be anything near psych. That's not me. But I went to my first psych clinical, and the people there, like, okay, in psychiatry, in most of nursing, you listen to the doctors, you just take, you don't just take orders, but it's not quite like psych. In psych, the beginning of the day, we do rounds. So everybody sits at a table, doctors, therapists, everybody, and the nurse gets to run it. So I get to sit there and I get to tell them exactly what's going on, my opinion, what we should do, all these things. And I'd never seen that in any other part of nursing, having that equal power. And that really intrigued me because I wanted that team environment. And then I started talking to the psych patients and relating to them in many ways and understanding that, it kind of takes one to know one, I guess. And when you go through a hospitalization process, it's really hard. And it's really hard to understand that unless you've been through it. And having that insight made me a very good fit for the job.
And you're treating patients who are similar to the people they interview, probably people on the streets?
Yeah. I've worked at a few different facilities. So I started in the public hospital system in New York, and that is what you'll see are most typical, what we can see are crazy on the street, talking themselves, yelling, potential for violence, but it's just the quintessential, you think schizophrenia, you think psychosis, you think yelling on the subway. That's who I'm treating. But I'm also treating alongside them. Like I could have one room with a homeless person, the next room with a sexual assault victim who may or may not be homeless. And then I have next to that, I'll have like a businessman. I have a white collar individual. I remember specifically there was one, all he wanted to do was talk about the stock market because he was so depressed, came in for a suicide attempt, no family, no wife, no kids, nothing. All he knew was finance. He knew how to predict stocks. He knew how to make money. And that's what he was good at. And he asked me every day to print out, the Dow Jones? Is that what it is? Mm-hmm. To print out all that stuff every day so he could look at it. And I would talk to him because I'd stay late sometimes and just talk to the guy. And I found out that pet food is a good thing to invest in, even in recessions, because everybody buys pet food, and beauty products. Beauty products are very good because you're still going to get your makeup. But yeah, you learn crazy stuff from these people all the time. You learn so much different stuff.
And what separates those people that are in the facility from the ones that are on the street? How are they so lucky to get treatment?
Well, it's interesting, actually. I worked in the psych ER. It's called CPEP, not CPAP, CPEP, Comprehensive Psychiatric Evaluation Program. Yeah. And I worked triage there. So I was the first person up front that decided, are you even going to get back to the doctor? Or are you going to have to go back out on the street? And that is a really interesting position because where I was working, you had not only people coming in psychotic, suicidal, or homicidal, you had people trying to come in to traffic people, to sell drugs, to do those types of things. And they would see the vulnerable population in a psych ward and want to jump on that. So you would have older women being taken advantage of, older men, all these different things, younger women being trafficked, all of this different stuff. And it was my job sitting up front to say, like, can you come back or not? You got to suss out the line. And unless you are extreme case, and especially in these days, unless you are actively a danger to self or others, most of the time you're not going to get admitted. There's other criteria, but it's pretty high bar to get admitted to the hospital for psych. It is, when you're in the psych ward in an acute hospital, it's pretty much the ICU of psychiatry. So
it must be difficult because there are so many people who are out of their minds living on the streets.
And actually, the bigger problem that people aren't really talking about is kids. We have a lot of adult beds. We have a lot of adult psych hospitals. We don't have that many kids ones. We don't have many people wanting to go into kids. And we have a huge problem with mental health with teenagers and younger kids these days. COVID,
where do they end up?
they end up in the psych ward as well, but there's far and few beds in acute
So the ones
psych
that can't
hospital.
get beds go where?
They end up in the emergency room for 2-3 weeks, months sometimes. I heard of a case that I had once where this little boy was in the emergency room for 2 weeks. And in the emergency room, you don't have any psych care. You don't get therapy. You get sandwiches, you get juice, and that's about it. It's an emergency room. It's meant for temporary stays. But these kids don't have beds, so they'll either go to the medical ward, not get their psych care, or stay in the ER. Or worse comes worse, they just get, discharged right back out until something worse happens. You get someone, like a lot of kids will come in and they will be self-harming. But there's not a bed unless they are literally trying to go for a artery. We have to push them down and we have to push them to outpatient. And then it's so frustrating because you have kids who are from GCFS and they don't have placement. It's called placement. So they will stay with me first up. I had one for 9 months in the psych ward that's not leaving the psych ward. That's not leaving that little unit, not going outside, not getting sunshine, any of that. And there's just not enough resources for the kids either outside or inside the hospital. And the wards of the state are just, I feel for them so hard. Some of those have broken my heart in the past.
What do we need as a country? I think we used to have mental health facilities for this.
In our history, we had very abusive state-run facilities. And instead of trying to make those better, we decided to shut them down and push everybody in the street. And that's a huge reason we have this massive homelessness problem. Now, to say keeping them in an abusive environment, that's horrible to do. That's not necessary in any way, shape, or form. But to push them onto the street, is that really more humane? Because once they go on the street, they're just cycling in and out of this what's it called, like ICU care of psychiatry. They're never being stepped down to the appropriate levels. How it's supposed to go and how it was planned to go before Kennedy got shot, essentially, was that they were going to close these big state-run facilities and make community centers. And so you could step down from this acute care, which is the inpatient psych ward stay, you go to a residential treatment facility. So you're still being monitored 24/7, but you can leave and you get some of these more, it's a less restrictive environment. You're still getting your meds, still getting taken care of, but you have a lot more liberty. Go from there to partial hospitalization, which is day programs. You're there for all day, 8 to 8 sometimes. And then you go from that to intensive outpatient. And then hopefully from there, you can just do your weekly or bi-weekly therapy. It's a very process that we have established. It's a very process that we have established. It's a